Okay, everybody. Now we are recording. So, as I was saying to everybody else, we are starting with a quick cardiovascular anatomy review tonight, just because it is such a big chapter and a big part of what we do. So, let's see. So everybody as an EMT basic went through basic anatomy, and we've reviewed it in this class, and I'm fairly certain quite a few of you have also had ANP1. But okay, I can't hear anybody, so, and it doesn't sound like it normally does, so you guys let me know if you can't hear me.
I can hear you, Debbie.
Okay. All right, awesome.
I can hear you.
Perfect. Thank you. So, you have your atria on the top and your ventricles on the bottom. Atrium receives deoxygenated blood on the right and empties oxygenated blood. So it kind of makes a full loop, the blood does, as it goes through. And this heart is pretty good, but we're going to see some better ones tonight. So when you're listening for blood pressure, what are you listening for? What is your systolic blood pressure? Your systolic blood pressure is what you're hearing anyhow. I think it's the Wi-Fi. Okay, so the blood pressure is all about these doors that it's talking about opening and closing. That also is going to be what affects your preload and your afterload. We're going to skip through some of this, but I really do want you guys to go back and review it. I'm trying to get to the parts that are important for you guys. So outside of your heart is the epicardium. And of course, the inside is the endocardium. Now your great vessels, and these are really important in our field, are going to be your aorta, the pulmonary trunk, and the vena cava. Your aorta, we have multiple things that can happen to that, especially when we get into trauma. That will affect a lot of what we do. Pretty much your great vessels are gonna, I'm trying to think of a way to say it that's not quite so booky, but they really do connect your heart to the rest of your body, which supplies your brain and lungs with the oxygenated blood and gets rid of the deoxygenated blood. Oh, hi. Let's see here. So obviously this is not quite to scale, but all my little buttons are gone now. You can see, your arteries, your veins, the heart, the lungs, your trachea. When you get to skills week, one of the things you guys are going to do is going to be, you'll be dissecting a heart. So you'll get to see how close this is to the real thing. Now, what we deal with is advanced EMTs is going to be more of the conduction system, the electrical, with your EKGs. With BLS, we learned the mechanical system, the CPR, the movement of the heart. Now we're learning the electrical side. It requires both to keep us alive. You guys are going to have to talk to me a little bit here. So, real quick, and feel free to shout the answer out here. Say, going back up just a little bit so you guys can see it. If we had, you can see where it shows the electrical pathway. I don't have my pen on here, and I don't know why. But if we have something that interrupts the electrical flow, what's going to happen to the heart?
It's going to start trying to reroute the electrical flow.
Absolutely. Now, which do you think this is easier? And do you think this is easier in a newborn baby or in someone of advanced age?
I'm going to purely guess a newborn baby because their heart doesn't have a big memory of the electrical pathway.
Well, you would think so, and I did too. However, the heart, as we age, starts recognizing that it's having trouble in certain areas. So it automatically builds, it reroutes the flow. That is why you are more likely to revive someone in their 80s than a 3-month-old. Because, and this is also why when we do CPR and they call for the initial defibrillation, this is why that is so important. The heart reroutes these flows. It has to be in pretty bad shape at an advanced stage to stop defibrillation. And we'll get into that more deeply later. I just wanted to do a quick look at some of the anatomy. And by the way, when you do your dissection, can you guys see the mouse? I guess you can't. Let's see. Oh, that's because there's no mouse on this part. Ducky. These chordae tendineae right here, they're really thin strands that turn from white to red. And the top, well, they go from the top to the bottom. Those are absolutely visible when we do the dissection. And I started playing with them. They kind of are like little guitar strings. But moving on, beyond my nerdiness. Right. You guys already know that the heart supplies its own blood as well. Okay, so let's talk about the pericardium for a second, because this is going to be a lot of our EMS calls, and we're going to get annoyed by them. But it is what it is. And that's the best way I can put that. So around the heart, kind of like in a fluid sac. Well, it is in a fluid sac. It is a fluid sac. Think of a newborn baby. You guys have all had OB. It comes out in the amniotic fluid, in the amniotic sac. The heart has its own little sac that it keeps it well moisturized, for one, which, okay, hold on. But it's going to reduce the friction. It's going to keep our heart functioning better for longer. However, the problem with this sac and that fluid is it can become infected, especially if someone is not treating their body right. It can become inflamed, and it can be super painful and feel just like a heart attack. It can also build up fluid, which is where we start seeing pressure being placed on the heart. This is my favorite picture ever, y'all. This is why I love when someone tells me they can't find a vein, because I'm like, look at all of them. Surely you can find one. You guys feel free to shout anything out you're thinking. Keep it PG though. All right. So going back here. Hold on. I'm pulling up your slides, guys. Okay, you ready? So I know this is a lot of material, and you guys don't have to learn all the itty bitty stuff, but I have got probably 300 different videos and resources that will be posted as soon as I'm not driving for you guys to review and to keep up. And this is why we broke this from half of a class into 2 full classes. All right, so you guys went over this. Out of those 4 listed, what do you think is the most life-threatening?
Aortic aneurysm.
Absolutely. And is the heart the only place that can happen?
No.
Correct. So don't dismiss those hypertensive emergencies, because let me tell you, they can throw some patients for a real loop. And of course, embolisms can always be dangerous. What is a thromboembolism?
It's when a weakened part of the artery bust and the blood goes out of the arterial wall.
So what's an embolism?
When it just makes like a balloon and doesn't rupture.
Interesting. But yes, we're going to be filling you guys up on that when it comes to cardiac assessments. So another anatomy real quick. Look at this chest. You can see how close the lung, the heart, all these great vessels, the diaphragm are. What do you think happens if the sacs around the lungs and heart start to fill up with fluid? Or
Compresses
air?
the heart.
Yep, it's going to compress the ones around it. So there's obviously not room for that. Oh, so apparently we're starting tonight, clocking in for our shifts, for our instructor stuff. Didn't know that. Hold on, everybody. Okay, sorry about that, y'all. We can turn over a lot of this. Pericardium is going to be the outside, endocardium inside. You can see the heart. I'm going to post some stuff before class ends that you guys will be able to see much more of the heart. Right now, I kind of want to get to cardiac disorders. So, and why they happen. And how you guys get to fix them now. All right, so everybody sees a cool little laser pointer. Go ahead.
No, I was just gonna say I don't see no laser pointer.
Yeah. Okay, hold on.
I got it now.
Well, I don't like red anyhow. So, there we go. Red on red is not good. You guys saw the picture of the heart. You saw the great vessels. You saw the arteries and the veins. Left anterior descending artery is where we see most, well, I won't say that. We see a lot of patients with blockages of the LAD. And just so you guys know, I can't see the full screen because I have the meeting app up. But you guys have the posterior and anterior view of a little Play-Doh looking heart. ignore that. Did your EMT instructors have you memorize the path of blood through the heart?
I think Rob taught me my EMT, and he really touched based on cardiology, but I mean I think I pretty much got it memorized.
Okay. Hopefully it'll be, I'm not going to ask you to name the complete pathway. Just know, how it empties through the artery or the atrium and the ventricles. Right now, as advanced EMTs, you guys need to know the electrical pathways through the heart. Just so you know, as we're going through this. And then we're going to get into blood a lot during trauma, so I'm going to try and touch a little bit more on it now. All right, electrical conduction system. What tells the heart when to beat? And don't just read the top line. You guys know this. Download that. What tells the heart? Yes, the SA node, but why? Well, that's okay. We'll go through this. I'm pretty sure they did not in EMT school. So the electrical stimulus is stimulated by the sodium potassium pumps. How much of it is in the heart is what of those electrolytes, they act on the electricity to tell when to send a signal out. And you guys are going to need to look that up. Know your sodium potassium pump. So when they send the signal out, the initial signal goes to the SA node. And the SA node takes that and runs with it. Think of the Olympics, how they pass that baton. Well, I guess it's a torch now.
You could say they were going to relay the message.
Oh yeah, but
It's a joke.
oh yeah, I like it. But I hate this part. The SA node takes that electrical conduction and starts running with it. However, imagine your SA node is a runner, but he's kind of out of shape. Whatever he was doing before he started the race left him in not so great of condition. So now you've got the AV node standing there waiting for SA node to pass it on, and SA node never shows up. So AV node, it doesn't really know what it's doing in the first part of the race, but it's trying. So it goes and it gets the baton, and runs with it, but it's a little slow because now it's running both its part and SA's part, and it doesn't look the same. It doesn't run the same. It doesn't act the same. I did clock in. Okay. If the AV node doesn't take over, AV node and SA node were partying before the race, and neither one of them showed up. What's going to happen?
You're
The
gonna have.
fibers should.
Wait, yeah, that's right. Someone said the fibers, the Bernicchi fibers. I can't remember what they're called.
The Purkinje?
Yeah, Purkinje.
Yep, absolutely. So it's going to move down, and it's going to get into the Purkinje fibers, which is where we get our junctional rhythms. You know, atrial rhythms, atrial. Ventricular rhythms, ventricular. I don't know where they found junctional, but that was neither here nor there. That's just me being weird. So, absolutely, the Purkinje fibers, they're coming from all the way down towards the end, all the way back to where the beginning of the race, catching that baton, running with it, but they're not making any sense at all. They're barely running. In fact, you could call it turtle crawling. And they're not doing a whole lot of good other than just staying in the race. Because let's go back to the SA node real quick. SA node, 60 to 100 beats per minute. AV node, 40 to 60. So if AV node is only running at 40 beats per minute, and we know it gets slower and less organized as we go on, what do you think is going to happen when we're relying on the Purkinje fibers to take over the race?
You're gonna have you're not gonna have enough cardiac output to really make the body function.
Right. So now we've lost our electrical signal. The electrical signal is what tells our heart when to mechanically beat. What does this become?
Asystole.
Pretty much, yeah. It's the heart's not going to know when to beat. It's not going to do its thing. So it's either going to stop completely or it's going to go haywire and give us rhythms like ventricular fibrillation, ventricular tachycardia, because now we're letting the ventricles take over. All right. This is a very important slide for you guys to memorize. No, don't memorize it, learn it. About what takes over when the first system fails. And you can see you've got your SA node, your AV node, your Purkinje fibers, your bundle of his. All right, cardiac cells. Yay, we're going to get close to the sodium potassium pump. So the heart communicates with itself. These cells respond to those electrical impulses we were talking about. That's the excitability of it, when they are responding to the electrical impulse. The conductivity of the cells is them to send out the message. Excitability, they're responding to the electrical message. Conductivity, they are sending out their own electrical message. And then automaticity, they don't need anything telling them, they're just going to do it on their own. Now, the excitability and conductivity, we have to have those for that electrical impulse. Hold on just a second. There's something backwards there. The heart has a built-in pre-plan with the brain for if all that fails. And that is going to be your automaticity. Automaticity. I cannot say that word, y'all. I also can't handle that thing anymore. Okay, there we go. We talked last week about the autonomic nervous system. Anybody in the room? Okay. Oh my, keep going. Y'all jump in. I accept jokes as tips. What is your chronotropic state? Or any of them, if you know any of those three, chronotropic, dramatropic, inotropic are. Anybody? Chronotropic, dramatropic, and inotropic are the speed and the force of how your heart beats. If it just barely squeezes versus if it's giving good, strong, radial pulse producing pumps. The homeostasis, which we also talked before. Okay, guys, we can't go through these PowerPoints. They're annoying and boring, and y'all need to actually see this stuff. I'm going to pause it. Nobody leaves. I'll be right back. I'm just going to take my screen off sharing for a minute. Hold on. You guys feel free to talk about the cardiac system while I pull this up. Hey, you guys can't see my screen, right?
No, it can't be.
Okay. One second. Then while I'm pulling this up, we're going to go over FISDAP real quick because you will be logging into that next week. and you will use it to document all these skills you perform so that we can prove that y'all know what you're doing. It's a part of your navigate. So when you log into navigate, you'll be able to log into all of that as well. It's not something new you will have to do, or it shouldn't be. All right, let me get screen sharing up because you will hear this in just a second. Okay. Yeah, we don't care about that. That is not the one. Hold on. I gotta pause the microphone or y'all gonna hear some new and interesting words. Okay, y'all, I apologize about that. So So that was the blood flow through the heart. No, let me see that. And that's it's simple. Your book is going to go way deeper into that, but that's as simple as you can keep it. Why do you think it's important to know the cardiac cycle?
So you can hopefully pinpoint where something is wrong if you have missing pieces of that cycle.
Okay. Yeah, so you know where something went wrong. Not right now exactly, but for those of you going on to paramedic school, and those of you who are nurses, what is something that we do that is vitally important to know what area of the cardiac cycle we're in? Defibrillation, trauma, blood pressures. We can know what part, without putting a patient on the cardiac monitor, we can know exactly what part of the cycle they are in just by doing a blood pressure. Look at this. The ventricles contract, we get systolic. Great. Diastolic, relaxation. No, it's not. So the heart pumps, we just saw it. When it's filled up with blood. And preload. The amount that's ready to be pumped out. You would think that would be when it's empty before the blood returns. But no, it's the amount sitting there ready to be pumped out. Our afterload is how much force it's going to take to get that blood out. And that's the beginnings of our perfusion, which is why we're here. You guys feel free to talk. So if we have a patient who has suffered some form of trauma and they are hemorrhaging out, which of these is going to be most important? Which of these are we concerned with?
I'm gonna say the preload.
Absolutely. If there's no blood return to the heart, there's nothing to pump out, and then there's nothing going to be left to build up our afterload. Correction, our stroke volume. Output. On the good news side of things, we can kind of help them with that. Not a whole lot. We just went through blood flow through the heart and pulmonary. So this is talking about cardiac cell ischemia. Before we get to that, back up. I forgot something. We're talking about ejection fractions, preload, afterload, output, stroke volume, all of that. You will hear a lot of patients talking about their ejection fractions. That is how much their heart is pumping out. A patient with an ejection fraction of 80, 60 is not doing so bad. You will have patients tell you that their ejection fraction is 18, 20. These are patients whose hearts are not going to hold up very well. What is another word for cardiac cell ischemia? Hey, William, do you go by William or Bill, or what do you go by?
People around here like to call me Joey.
Oh, okay. I can call you Joey. All right,
Joey also has a rap name too.
really? Do tell. Let's hear it.
Well, my rap name?
Yeah.
You have to subscribe to my OnlyFans first. Sorry.
Oh, okay. Well, we'll see about that one. I bet you I know it because I'm fast. You guys feel free to talk, make jokes, ask questions, say what you know about this stuff. Because if I know you know it, we don't have to go through it as deeply. And we're not going through it very deeply because you should know this. But, so what do we call cardiac cell ischemia?
I know it, but it's on the tip of my tongue. It's like I know it because it's just the verbiage of it. Cardiac cell ischemia is,
It is not MI. I will help you there. We're going to get to that in a minute. So ischemia is when this area of the heart is not getting oxygen. It's not doing well, and it's not getting oxygen, and they're going to have chest pain, discomfort. They are not at this point having an MI.
Wait.
And if you think, what's that?
Okay, I feel like I'm onto something here, but you know, it's I kind of had to take a break from this a little bit because there's some things going on, so I'm kind of jumping back into it with a small break. But can this be caused by pulmonary edema, or am I lost here?
Pulmonary edema is going to be more than fluid.
Okay, the way I'm thinking of it is because you know ischemia, it's the heart cells, they're not getting oxygen. Something is stopping the oxygen from circulating back into the heart.
Yes,
So,
absolutely.
Hey, I'm on now. Hey, is it cardiomyopathy?
It can be. There's a variety of things that can be ischemia, blood clot, hypovolemia. Ischemia is just the condition where they have stopped receiving oxygen to that part of the muscle. Yes, angina. They're going to have angina, chest pain. Ischemia on its own is not life-threatening for our patients. It is dangerous. It is not life-threatening on its own. However, if it's not corrected, if we don't get these patients oxygen and volume of blood to get that blood flow and the oxygen back to the heart, that's when we have a problem. What does MI stand for?
Myocardial infarction.
Exactly. Ischemia is just started to not get oxygen. Infarction, that area of the heart is dead. It hasn't gotten oxygen. It ran through all of its back supply. It's caused chest pain and nausea and every other symptom that our patients are having before the infarction happens. And nothing has been corrected. So now it's like, I give up, and it dies. The patient does not die. That part of the muscle that has not gotten any oxygen dies. The patient's going to be miserable. Any questions about that? We're not going through this right yet. Because as you can see, it jumps right back into myocardial ischemia. Hold on. It's not showing you the same page as it's showing me. Okay. Coronary artery symptom. This is, I feel like, their way of calling us crazy. Because it is just a term for the symptoms. It's not an actual condition. It's the term for the patient is complaining of cardiac symptoms. As you can see again, ischemia. Decreased blood flow to the heart, decreased oxygen to the heart. They're going to have chest pain, difficulty breathing, nausea, jaw pain, possibly altered mental status. We treat it just like we would an MI in the field. We're going to go deeper into that once I'm not on here. What is the treatment for an MI?
Talking about aspirin.
That's one of them. What else? What you got? Anna, feel free to jump in.
Nitro.
Absolutely. What else?
Meth lab.
What? Did you say meth lab?
Cath lab.
She said cath lab.
Cath lab.
Oh my gosh, I was getting really worried there. Yes, cath lab, not a med lab. So that may treat it as well. You never know. They're going to get fluids, oxygen, and ran pretty quickly to the cath lab. Because if we don't treat this ischemia, what's going to happen?
Gonna die.
Muscle death.
Mm-hmm. Angina pectoris. Again, not getting enough oxygen. It's pain. Angina is chest pain. Literal definition right there. Chest pain. A pain in the chest. So, what is, you guys can see on here, it talks about stable and unstable. What's the difference?
One of them occurs kind of in a pattern. The other one is just, you don't ever know when it's going to come about. It can come and go and stop and start at any time.
That's absolutely one of them. Yes. What else?
Isn't one
I'm sorry, I missed what you said. Hannah? Not quite coming through. But, so another, did it start at rest? When you're talking to these patients, they're complaining chest pain. Well, when did it start? What were you doing? If they tell you they were watching Jerry Springer, that's stable. If they tell you, well, I was taking a nap and it woke me up, that's unstable. Progressive is just getting more frequent, more painful, won't go away. That's usually when older patients will call EMS. When it's progressed to, it's kept happening more and more frequently. Now I can't get any rest. It hurts too much. They're used to having chest pain. So by the time we get to this point, we need to be a lot more concerned. So something keeps messaging me on here, and I think it's y'all's, but it won't let me view them. All right. So now we're getting up to our actual heart attack, or actual infarction. This is when the cells are dead.
Can you hear me now?
Yeah, so much better.
Okay, I'm at my mom's and there's a billion kids here, but I went
Oh.
outside.
Oh, okay, I got you.
Yeah.
All right, not a problem at all. We're just talking about, we've moved from ischemia to infarction now. The cells are dead, there's no reviving them, and we are on our way to the cath lab with this patient. We're seeing their EKG, it's a big O STEMI. We're applying diesel treatment. What else should we be doing while they're getting their diesel bolus?
Continuous vital signs.
Absolutely. You guys start thinking of advanced. When I ask you a question, I want the advanced EMT answer. And by the way, you got a pet dog and I want to
Sorry.
No, you're fine. All right, so what else we got?
Well, I know would you get the blood glucose before y'all get there, or because I work when y'all bring them in, so.
Okay, Yeah, we need to figure out what else. So we've got a patient that we did an EKG on. They're having a heart attack. They're complaining of chest pain radiating into their jaw and left shoulder. So far, that is where we are at. We have identified that we're having a cardiac event. Which, you're absolutely right. We need to be getting a blood sugar. What else are we going to do? And vitals.
Are you talking about other than aspirin and nitro?
Okay, hold on just a second, Hannah. Yes, aspirin and nitro. Hold on just a second. So, absolutely, aspirin, nitro. What else?
I mean, they would probably want an 18 gauge, right?
If at
IV?
all, yeah, you're going to want IV. You're going to want to have fluids ready. You're going to want some oxygen on this patient. Why is this patient having this event? What led to this event? Internally. I don't care that
Oh,
he's
you're
flushing
talking
through his
about
hair.
the history, I guess.
No,
Right.
just the patient, the reason that they are having an infarction is because their heart wasn't getting enough oxygen. We don't need more area to die. We want to get this patient on oxygen. A chest pain patient is the one time I will tell you that, yeah, go ahead with that non-rebreather, 15 without any respiratory symptoms.
I got you.
Yeah. All right. So you guys know the signs and symptoms. You're not going to see every symptom every time. Every patient's different. Women, and especially female diabetics, are going to have a lot worse symptoms. No, I take that back. A lot different symptoms than males are. Women who are over 45 and complaining of certain things always get a 12 lead. Look at the signs and symptoms and tell me what you think those complaints would be.
Atrial fibrillation with the rapid ventricular response.
Yeah, that would be a sign or a type
Oh.
of rhythm. Like, what are these symptoms?
Oh, my bad.
Yeah, what do these symptoms look just like in another illness that's not cardiac?
Having a like a gallbladder attack or acid reflux attack.
Yep. What else?
Pneumonia?
Yep. What else?
Maybe.
Absolutely.
Anxiety attack minus a few of the really bad kinds of things.
Absolutely, and we see that a lot. What else you got? Keep throwing them at me.
Drug use.
Drug and alcohol. Patients will be complaining of, weakness, nausea, sweating, and they don't have to match all symptoms. What's something really common, unfortunately, that we get called for that matches these symptoms? But
Hello?
yeah, you hear?
Yeah, you cut out on the last part.
Oh, what's something we get called for all the time, especially this time of year, that matches all of these symptoms?
COVID?
Well, that too. We get called out for the flu. We get called out every day, multiple times a day for people. I don't feel good. I've been nauseous the last 3 days. I've got the flu and I want to go to the hospital. They're spreading because they're feverish, they're nauseous, they're having chest pain and pain throughout their body. Sometimes they pass out because they've not been eating or drinking and they have no blood pressure. So we get called out all the time for the flu. However, look at those symptoms. Look at flu symptoms. Especially in women. Women over the age of 45 always get A12 fleas. Unless they're complaining of something like, a broken arm. Oh, by the way, if you have a sudden death patient, he's got bigger things to do than that 12 leave. Eventually, they need that 12 leave, but yeah. I had somebody argue with me on that one once. Patients know when they are about to die. Patients know when something is seriously wrong. These patients will tell you, well, they could tell you, hey, something's not right, I'm about to die. Hey, can you contact my family and tell them I love them? Or a very different message towards the family. They're going to be scared. My lady the other day accepted it fully. This was not her first heart attack. She said, I've survived two. Something doesn't feel right with this one. I think something's majorly wrong. I didn't tell her, but I felt like something was majorly wrong too. Her heart rate was in the 200s. You guys know this stuff. All right. Which of those do you think a patient could be having a cardiac event? Which of those rhythms?
See?
Okay. Anybody else?
Can you ask the question again? I didn't hear it.
Okay. Which of these rhythms do you think would show if your patient was having a cardiac event?
Well, D, because it's in defib,
Absolutely. What do you think, Joey?
and E,
No, that patient ain't having any events now.
Patient's dead.
Yep. All right. Hold on. So yeah, all of these rhythms could be a patient having a cardiac event. A normal sinus rhythm is what it looks like. Maybe a little fast, but essentially a normal sinus rhythm. However, you never know. B, bradycardia. That right there is cardiac. C, VTAC. VFib, asystole. Asystole is no longer a cardiac event because it's not actually doing anything. But it's lethal. So, oh, what happened here? Cardiogenic shock. We're going to get way deeper into that when we go through shock. But it is absolutely just as dangerous as neurogenic shock, distributive shock, objective shock. It is when their ejection fraction is not moving any part of I'm looking to see where this is at. Okay. What do you think a patient who is in cardiogenic shock, what do you think their biggest complaint is going to be?
They can't breathe.
Okay, what else?
they're going to feel like they're grounded.
Very possible.
And dizziness too.
You think they might be? Yep. You think they might be complaining of the same exact things that flu patient's complaining of that we looked at earlier? Initially, anyhow.
Yeah.
Absolutely. Check these patients out. Make sure that a horse is really a horse and not a zebra in disguise. Big difference with that flu patient is not gonna. They may have a dysrhythmia. They may have some edema if they have a history of CHF. They are not going to have jugular venous distension. That is going to be your cardiogenic shock. All right. So you know your treatments. Position of comfort. Now, when I say position of comfort, that doesn't mean on all fours staring out the front windshield of the ambulance. But as comfortable as you can make them. Here lately, I've had a few patients get that confused. They're going to be cold. It's okay to put a couple blankets on them. They're not running a fever or anything like that. They're going to need the oxygen. All of these cardiac events come from not getting enough oxygen to the heart. Give them their oxygen.
I actually have a question. I said I actually have a question about that. So, a lot of the times when we get our STEMIs, and shock patients. So I went to put a bunch of blankets on one, and they all freaked out on me and was like, "Don't do that! Don't do that!" She said something about the cold preserving the heart tissue.
And they're absolutely right. In the ER, that the cold can preserve. And however, this patient is going into shock. And the
Right.
only way that we keep that blood moving, what's left, is to keep them warm, just like with any other shock patient. That being said, there are times, especially in the ER, that they need to do cold therapy. It's the same general principle as when we do hypothermic therapy after cardiac arrest.
Okay.
Yeah, but while we're transporting, if that patient is upset and already experiencing, a racing heart and all this other stuff, and they're cold and they're shivering, that's just going to drain them faster.
Right.
So is the stuff in the ER is amazing. Sometimes in the ambulance we have to go a little bit different direction, at least till we get them there.
Yeah, I didn't know if it was the same, and
It is.
I'm gonna
It's
have to.
just
I know I'm gonna have
different.
to unlearn a lot.
Yeah, but you know what? That's not a bad thing, knowing both sides. So heart failure. Yay. Long-standing high blood pressure. Let's talk about that for a second. These patients, especially in today's age when everybody has high blood pressure, I dare you to find me 10 patients without it in a month. Not you, Hannah. You see too many patients. These patients are wearing out their hearts. That high blood pressure is going to land them on renal dialysis, CHF, all kinds of crazy stuff that. Okay, you going for a minute, Donna. They're wearing out their entire body. It's not just, oh well, I have to take a pill for my high blood pressure. Look at all the stuff that can happen to them, and it all starts with the heart failure. Because anytime after long-standing high blood pressure, that's not 25 years. That's days. what is something you see on this page that is familiar, that we deal with every single day?
Congestive heart
Chronic
failure.
hypertension.
Yep, all of it. So left-sided heart failure equals what? Oh, sorry guys. Hold on.
Wait, what did you say?
Sorry, I'm moving something around. My plate is right between
Oh, okay.
where I need to be. So with the, I really want to know what that noise is. It's driving me insane.
William still left.
Oh, okay. You're just to get through this. Try to get through this part a little bit for you guys. Left-sided heart failure leads to right-sided heart failure. Right-sided heart failure is the patients that look like the Pillsbury Doughboy because they're so filled with fluid. When you poke them and their skin doesn't pop back out when you let go, being edema, that's going to be your right-sided heart failure. That's also going to be your renal failure and a patient in a whole lot of pain. One of my but most enlightening moments as an EMT was we had this patient and I was getting an IV for my paramedic partner, and I stepped the patient and something that looked like pink lemonade came out. And I had never seen it before. I was a brand new EMT, and my paramedic started laughing at me. I wasn't sure what to do with it. I was like, I'm not sure this is blood, man. What the heck's going on? And it was because of the amount of fluid that was in that patient. All it was pink lemonade. All right, pulmonary edema, PHF. These are patients that you're going to want to put on CPAP. They may end up intubated on a vent. When you get them to the ER, if they have severe pulmonary edema, they're definitely going to go on BiPAP. But you don't really even need any medications for this sometimes. Put them on CPAP. Have them keep that PEEP, and sometimes that will at least clear out their lungs so they can breathe. This is not a patient you want to start a nebulizer on. And it is definitely not a patient you want to do IV fluids on. What's a good treatment for this patient?
Steroids
Huh?
and Medrol.
Yep, absolutely. Medrol. What else?
I would just make sure they're sitting like upright.
Absolutely, you're gonna want to keep this patient upright.
What, a 90-degree angle? Is that right?
If at all possible. Some of your larger patients may not be able to sit up like that, but you can stuff pillows and blankets and whatever you need to behind them. This is a patient that's going to benefit from nitroglycerin and oxygen and CPAP. Those are your treatments. We have Lasix. It is not currently an advanced EMT medication, and most paramedics won't use it because the patient tends to pee all over you. Because fill a swimming pool sometimes. But it works really well, and it works pretty fast, all things considered. All right, hypertensive emergencies. We have patients with hypertension all the time. What makes it a hypertensive emergency?
When it goes above 180.
It can. We
And
have
they
patients
can't.
that live above 180.
It goes above,
I was about to say.
yeah, but it goes rapidly up, and they cannot get it to come back down.
Absolutely. What will the patient be complaining of with this hypertensive emergency?
Dizziness, nausea, maybe chest pain.
Absolutely. What else?
Headache. Headache.
Yes. Why is hypertensive emergencies hypertensive emergencies? Or why is
Stroke.
hypertensive emergencies emergencies? Stroke is one of them. What else? We talked about the anatomy of the heart earlier. What's something that can rupture with hypertension?
It,
The aorta.
yeah.
Yep, the aorta. Actually, any part of the vascular system, because it's putting so much pressure on it that it can't hold it. This patient will be complaining of chest pain. Or
Don't give them aspirin.
don't give them aspirin, don't give them nitro. There could be a reason they're hypertensive beyond what we can see. And if they're hypertensive because they need that, their body is compensating, and we give them that nitro, it can kill them. IV access, no fluids. All right. How long? So you have your hypertensive patient and hypertensive crisis, and say it does rupture the aorta. How long do you have to get that patient to a surgical suite?
Mm-hmm. Well,
Usually just minutes.
yeah.
Not even. I'll give you guys this hint. If the femoral artery is ruptured, hemorrhages, whatever you want to call it, you have between 1.5 and 3 minutes before it is completely bled out. The body is completely bled out. You have right at, I believe, 1.5 minutes with the carotid artery. The aorta, right there where all the blood should be. How long do you think you have?
I mean,
Less than a minute.
Say bye. Can you tell him bye?
bye, bestie.
Say bye. Blow him a kiss.
Sorry.
Oh, you're fine. You have around 17 seconds. If the aorta ruptures. So when I say these patients are sick and this is something you need to study, I mean it. Which reminds me, you guys make sure you study, because there's definitely going to be questions on your exams coming up. Each part of the body and how much blood or how long a rupture of that area would take to bleed out. Now, if you have a patient who ruptured the aorta and they're hypertensive, they won't be for long. Their 180 systolic blood pressure is going to become a 60 systolic blood pressure real fast. Of course, they're not going to be awake for it. Actually, it's going to become a 0 systolic blood pressure, but you know what I mean. Aortic aneurysm is weakness in the aorta, just like it says. When it dissects, the layers separate. That is not a ruptured aortic aneurysm. That is a dissecting. Dissecting, the layers separate. Ruptured is going to be when you have just a complete tear. There's no layer, it's the whole thing tears. Or shear. In trauma, you can shear your aorta. And again, uncontrolled hypertension. All right, primary survey. We are not getting into the BLS skills. Primary survey, major thing, make sure you're safe. That's always your number one. The stuff we talked about is going to be your quick killers of patients. This is stuff you guys know. The only thing you're adding in is you have a circulation problem, so it's already going to be a life-threatening event on your primary survey. What did I say last week about a medical assessment?
It can be specific to body part or illness.
Yeah, this is secondary, and it absolutely can be part specific. What are some questions you're going to want to ask these patients?
If they've ever had a heart attack before,
Yep. What else?
if they have any known heart problems,
Yep. Or known family problems.
Hey, Ducky.
Yeah.
I'm sorry. My grandfather's on the phone. I was just trying to see, what time do you think we'll end tonight? Because I was bringing them over there, the kids.
Oh, I'm
I
not
just have to
sure.
work. That's
Yeah,
why.
yeah. Go ahead and go log. We can get you log back in, and I can send you some notes on
What?
it.
Well, I was gonna go around 8. That's why I'm saying, like, if we're gonna be done around 8:30, that'll work out.
Okay, yeah, that'll work. I'm in a different
Okay.
time zone right now, y'all. So
Oh,
ignore the confusion. Yeah,
okay.
I'm in Tennessee. So okay. I'll try and speed up through some of this. At least the PowerPoint. Next week's not going to be any PowerPoint at all. Or next class will be no PowerPoint at all. If we get through this. You're going to want to ask them what medications they've taken. Blood thinners. Have they been taking them like they're supposed to? Did the patient with AFib stop taking their blood thinners 3 days ago and is now having a clot? Is the patient with ED who's complaining of chest pain going to become severely hypotensive if you give them medication? It all comes back to our pharmacology as far as this part goes. Know your drugs. At least know your or prefixes and root words, because know if this patient is on blood pressure medicine and saying they took it today, and or you recognize your patient's on blood pressure medicine, they tell you they took it today, but when you start to question them and you start assessing them, their blood pressure is 240 over 150. That's a huge problem, especially if they're telling the truth. You guys know about sample history, allergies. Just like you said, heart problems, diabetes, something that will hide their symptoms. Kidney disease. The heart and kidneys work together, especially with the whole fluid overload. I would not advise asking anyone if they're stressed unless you want to be stressed too, because everybody is stressed right now. This all looks familiar. It's stuff you're going to do with every patient. And then always, every 5 minutes or so, repeat your primary survey. Are they breathing? Is their airway clear? Is it normal? Are they getting enough oxygen? All right, quick question for you. You're in the back of the truck with a female patient complaining of chest pain. You get vitals. Her blood pressure is 150/90. Heart rate 102. O2 97%. What's something you want to do for this patient?
You said 150/90?
Yep.
I mean, that's what mine runs usually. uh,
Starter on oxygen.
Absolutely. These patients are not getting enough oxygen to their heart. They're having the chest pain.
After she's having chest pain, is she having chest pain?
Yeah, she said she's having chest pain. Her
oh, I
blood
missed
pressure
that
is
part.
up.
I'm sorry.
Oh no, you're fine. So
Aspirin?
After she's taking any nitroglycerin or aspirin, if she hasn't, go ahead and give that.
absolutely. What's something you want to ask before you give them aspirin?
Oh, yeah.
Allergies.
Yep, allergies. What else?
If they're on blood thinners?
Yep. What else?
If they have a history of hypertension, maybe? Or if they're on the medication for it?
Yep, absolutely. Anything else?
How long has it been going on and what brought it on?
Yep, absolutely. Anything else with aspirin?
Oh, I feel like I'm missing something. If they've already taken it, maybe? I'm not sure.
That too.
Ask if they have any like history of stomach ulcers or internal bleeding.
Absolutely. If the patient tells you that she's having chest pain and you ask, you have a history of any kind of bleeds, and she goes, oh yeah, I've been bleeding every time I go to the bathroom for the last week. I wouldn't advise giving that aspirin. It's not going to end the way you hope.
So if they have a headache and chest pain with hypertension, you don't want to give aspirin then, right?
You can give aspirin. You do not want to, if they're hypertensive with chest pain, you can give aspirin. You do not want to be giving nitro.
So it's only if it's like 180/120 and higher is when you don't give it, right? The aspirin?
That would be nitro you're
For
thinking of.
Well, I just meant earlier because we said stroke or whatever.
Yeah, that's nitro. You don't want to decrease their blood pressure suddenly.
Okay.
Talking to the patient, calming them down, you may see their blood pressure start to improve. These are patients that could lose consciousness, could begin vomiting. Be prepared for any outcome. IV access if you can. Hypertensive patients, you'll usually be able to get a pretty good access. Hypotensive, forget it. All right, we just went over nitroglycerin. Don't touch the nitroglycerin with your bare hands, especially if you pour the bottle upside down, because you may get a headache and some lowered blood pressure as well. So, without really looking at the wording, look at this picture. What do you think is going on with that patient?
He probably had a bypass.
That it?
Yep.
That's what I found on the table.
Yep. They've had another type of surgery too, but
A cabbage.
well, I was looking at their stomach. They've had something else too, but they've had yes, a cabbage, coronary artery bypass graft. Oh look, and there it is.
Oh well.
A lot of times you can find matching surgical scars on their chest and leg because they take them from the leg before they'll take them from the chest. Now they're taking them from the wrist occasionally as well. This is not a patient that is taken to the cath lab and fixed. This is a patient that is taken to the cath lab. Things don't go well in the cath lab, and then they have to go for a cabbage because either the blockage was too large or too deep into the vessel. For example, my dad has a widowmaker blockage right now, which he cannot have surgery for it. So the plan is, if something happens, he will go straight into surgery and get a cabbage. He's refusing surgery also too, but he's a bonehead. Pacemakers. So most of the stuff we've talked about so far has been illnesses, diseases, and emergencies based on the mechanical function of the heart. Hypertension, all that is mechanical. Now we're going to talk about some of the electrical side, the electrical conduction. Does anybody know how a pacemaker works? Or actually gotten to hold one? They're tiny and wonderful and kind of creepy. They don't just put a defibrillator in post-cardiac arrest patients. I want to go through defibrillator too because I'm going to talk about them both at the same time. You can see the pacemaker defibrillator in this patient. Patients who have atrial fibrillation. These patients tend to get pacemaker defibrillators. Patients who keep having junctional rhythms, whose hearts keep going over 150 despite medication and other treatments, they're going to get a pacemaker defibrillator because their heart is obviously not going back to what it's supposed to be doing. External defibrillator vest. That is going to be your life vest. Typically, my family member actually has one. I will give you one guess who the only healthcare provider is who is allowed to take that vest off once it goes on the patient.
The cardiologist.
Nope.
The people that make it.
Nope. Well, probably, but two, but I'm not sure the second one's a healthcare provider.
Oh, okay.
Keep guessing.
Oh. You said the only person who's allowed to take it off?
Yep. Of a live patient.
Mm.
The EMT when they're live. We can take it off to do CPR.
Yep. EMS, because we put them straight on the defibrillator pads and we stay with the patient. Sometimes in the ER, they'll take them off. But typically, EMS are the only ones allowed to take that vest off. If the patient goes to the floor and that vest goes up with them, they cannot remove it. Well, they're told not
I've
to.
never seen one before,
They
surprisingly.
are very impressive. It's very clear if one has been off because they're going to have blue gel all over them. They're going to look like a Smurf. And there is a little box on them that is going to tell you that it's been off because it will not shut up once it goes off. And it tells the patient before it shocks them so they can sit down or whatever. And it sends a prompt to their physician saying that it has defibrillated them. Now, what do you think will happen if you put your hand between that vest and that patient's chest, say to take a listen to their lungs or something?
Knock a lead off.
There's no leads in.
You might get defibrillated.
You very well could and probably will because that vest is going to lose the reading of their chest because your hand is in between and it works through sensors. So it's going to think that there's a change in the rhythm. It's going to do what it knows to do, which is shock. And you're going to be in a lot of pain. That's another reason we take them off, but we make sure we have them on the monitor, on our defibrillator, on the monitor with our defibrillator pads on them before we just, take it off and leave it off. LVADs. I'm going to tell you this the best way I can. LVADs are not EMS friendly. There is nothing that we can truly do for an LVAD patient other than call for a helicopter and get them to whatever hospital put that LVAD in. That is the only hospital that can treat them. If you have a patient with an LVAD, they will not have radial pulses. You can listen to their heart and you will not hear beats. You will hear like a pumping, kind of a whooshing noise because the patient no longer has a heartbeat of their own. These are not patients waiting for pacemakers or defibrillators. These are patients waiting for heart transplants. The LVADs are only in them until they can get a heart transplant. Oh, and if you are somewhere that has a LVAD patient come in and they don't care, ask them if you can feel their pulses in their wrist and listen to them. A lot of times they're fine with it, but it's very cool to hear and very different. You will also not be getting any blood pressures on these patients. And like I said, the best help you can do for them is call for a helicopter and then call the number that is on the back of their device. Let them know that that patient's coming in, something's not right, and you need the records from the LVAD because it records everything. Cardiac arrest. You guys are familiar with cardiac arrest. Is cardiac arrest death? What do you think? Is cardiac arrest the same as death?
I can't understand you, Ducky. What you're saying is cardiac arrest, what?
The same as death? Medical death?
Yeah.
Yeah, you think so? What do you think?
I guess it depends on what stage is the cardiac arrest in. It may not be medical death because you may bring them back.
Possibly. CPR. However, the thing is death is the absence of brain activity. Because we can put them on pacemakers and defibrillators, and technically speaking, we can take their heart out and do the pumping for them. We can have them on an LVAD. We can have them on a ventilator breathing for them. We have nothing to keep the brain going. We can monitor it, but we have nothing to intervene. So death, legal death, is the absence of brain activity, which is why we do CPR on folks. Oh. Hey, I figured out what that noise was. It's every time I click the button and it found something that is not clickable. Okay, so because the patient is not legally dead, because they still have brain activity, we're going to do CPR. We're going to defibrillate. We're going to do everything we can to help the patient regain pulses. Have you guys used a defibrillator before? I'm fairly certain you have, Donna.
Yeah, sorry, I had to step away. Yeah, we use defib pads though. It's like a little thing hooked up to the monitor in the ER. It's not
Right.
like it's on separate.
Right. We have those hooked up to our monitors in the truck. The defibrillator, it's going to tell you whether or not to shock them. Okay. So, but you're advanced EMT, so you're going to start using the monitors more and more. You know how to use an AD. You've been through it in every CPR class you've taken, which you had to have to get into this class and to get into EMT class. So I trust that you know how to use an AD. All right, here we go. We get a patient in cardiac arrest. We have our chain of survival. And think of these as early in front of all of these. What is the first thing that we can do that the average Joe Blow off the street can't to improve their condition?
You mean like in the chain of survival or just like starting IVs and stuff?
In the chain of survival.
Oh.
We can start CPR, can administer oxygen, defibrillate them. Of course, I mean, most of the general public can defibrillate them now, so they have access to it.
Yeah, but a lot of them won't because they're afraid of hitting with electricity. They can, or they don't have access to a defibrillator, all these home cardiac arrests. So that's one thing we need to be checking for. Is this patient a patient to defibrillate for? That's one of the first things, because especially if they've been getting CPR from the neighbor or whoever. While we are on defibrillation, I need to go back for a minute. Really important safety note about life vest. Before you take the life vest off, EMS, if you're able to put the patient on the cardiac monitor on defib pads, right now in your truck, don't do that. Not until you're advanced. But if you do take that life vest off, before you take it off, before you start touching it, take the battery out. Again, the vest is going to read if something is wrong with the patient's rhythm, and it is going to shock. It does not care if it shocks the patient or you or your partner. So make sure you take that battery out. But yeah, defibrillation, super important. The majority of patients we get are not defibrillation eligible. You guys know not to get in the pool with the defibrillator trying to defibrillate them.
Yeah.
One time that CPR should be, hold on, I'm going to pause the thing. That's one time that we interrupt chest compressions. It's really the only time. And now with the new updates that are coming out, I'm not certain if it's been approved yet for this go round, but they're even saying to continue compressions during defibrillation because it's not enough to damage the responder. I'm not saying to continue. I'm saying that's what AHA is saying. Me personally, I'm not touching that patient while they get defibrillated. What do you think, Miss Donna? Would you continue CPR while they're being shocked?
No, I've been shocked before. So just like
Yeah.
from the stretcher and all, and it's a little bit too much for me to volunteer to keep doing CPR.
Yeah, I kind of feel the same way, especially considering that they say it cannot damage us. Not that it's not going to hurt us. It can't damage, which is long term. I don't want short term either. All right. So,
And they can't say that. I mean, what if you have an underlying cardiac condition yourself and
absolutely.
you get zapped with 200 joules? How they know that's not going to put you into a cardiac arrest?
Absolutely. So, if somebody tells you, "Oh, it's okay, keep doing CPR," offer to swap with them and let them do the compressions while you shock the patient. Just gonna leave that one there. If a patient goes into cardiac arrest while you're transporting them, you're the only person in the back. If you have to, have your partner come back and help you. But the preferred method is keep driving, have an ALS truck meet up with you, or a paramedic unit meet up with you, or get to the hospital, whichever is faster. Don't stop to do CPR unless you need to get an airway, something like that. Don't stop for an IV. Keep going. Defibrillate if you can. Keep driving towards the hospital. Which is more beneficial to the patient? You sitting on the road sitting on the side of the road waiting for a paramedic unit, or to do an IV and an airway, or continuing compressions and BVMing and getting them to a hospital with a cath lab?
Hospital is your first priority. Get there as quick as you can.
Absolutely. Absolutely. All right. So this is talking about your increased role as an advanced EMT. Why is that so far behind?
Why is what so far behind?
Huh?
You were talking to yourself and you said, why is it so far behind?
Yeah, everything you guys are seeing and hearing is apparently a few seconds behind what I'm doing. So you have going into cardiac monitoring, which is going to be one of your new and improved skills. You're going to be doing some EKGs. You're going to be hooking the patient up, transmitting the reading. You have a patient that calls for chest pain. They're laying in bed. Where do you want to do your EKG at?
Where it's still.
Preferably where you found them.
Yeah.
Absolutely. What's going to happen when you get that patient up, moving them around, getting them on a stretcher, getting them in an ambulance?
That rhythm's going to change, possibly.
It could. What else? Well, the rhythm's going to change. What could happen?
You can, I mean, I guess if they're bradycardic or something, they could pass out. We do EKGs, and I mean, we usually just try not to move them too much if they come in needing one.
Right. When we're doing them in the house and we're going out making initial contact for chest pain, we don't know what's going on yet with that patient always. However, if they are having a cardiac event, not just STEMI, something more lethal, usually. And we start moving that patient around, they could easily go into cardiac arrest. Even if we get them back, if we had that 12 lead, that initial, we could see if there is a STEMI or not to know whether this is a patient that went into cardiac arrest from something else or if it's from chest pain STEMI. It could be respiratory death. It could be narcotic overdose. When you're doing CPR, that stuff matters slightly less. We'll get into our H's and T's. But if you get the patient back, that is vitally important, knowing why they went into cardiac arrest. Does a patient that overdosed on heroin and went into cardiac arrest need to go to the cath lab? Absolutely not.
No.
Right. But a patient who is having a STEMI or some kind of cardiac event needs to. Try to get it before you go moving the patient around too much. And that's my major reason for it. You guys are going to be doing the skill in Skills Week, learning to put the monitor on. You're probably already pretty familiar with it. I know you've both done it before that are in here. For those listening, if you haven't, it's fairly simple. And we're going to show you some tricks during Skills Week to remember where everything goes, to remove hair. That's always a fun one for the guys. You get to be our EKG dummies. And how to make everything stick and read correctly going down the road. If you are going to shave the patient or whack the hair off a patient, don't rub alcohol on them. It's not pretty. All right. So that's the end of that first part of cardiac. Brief skim. You guys can go through and read. The notes are wonderful for this part. There's a little bit more we're going to do. However, if anybody needs a break, needs to use the restroom, go ahead while I get this other part pulled up. Okay? You guys still there?
Yeah.
Okay, cool.
Yeah.
Okay. Let me know when you're ready to start.
What? Start. Okay, I see.
This next part. This part won't take too long.
Oh, yeah. Did I seriously just drop it again?
What?
Sorry. Can you hear me now?
Yeah.
Oh, okay.
And we're going to go into the more recognizing the diseases a little bit more Thursday as well, and get any questions anybody has, and have a thoroughly non-PowerPoint day on Thursday. Okay. Screen's off, but you should still be able to hear. I'm going to pull up a few of these files that I need you guys to look at. All right. please. And any extra breadsticks I can get since I'll be eating them and driving. Y'all, I am a chunky kid. I like my breadsticks. All right, you guys ready to start back?
Yep.
All right. So, here we go. So this is in your Navigate. It is not in your book. And this is more in-depth look at the heart and how it operates. I can't get to the scroll button. Hold on. Drive me crazy. Okay. So there's an app called the Visible Body or the Human Atlas. Either one works. It should be free for you to download. That goes very much in depth inside. You can move it around, look at different parts, layer them, build the complete heart, or break it down to a tiny cell. So it's great, and it will also be good for when we go over the brain. The big thing I wanted to do today was go over anatomy. All right, so I'm just going to make this real quick. This paper will be very important for your testing. Go through there. There's different things you can do, different labs you can do, per se, to figure out what you're looking at. Be able to answer some of these questions because you're going to see them on your exam. I think I've lost everything. All right, so all of this is going to also be in your book as far as being able to answer the questions. But it's a good resource to study for your test, and you're also going to see some of these questions on your national registry when you go to take it. For example, what is the only artery in the body to carry oxygenated blood?
Pulmonary.
Yep. So your national registry and your testing is going to ask you a lot of this, because I really feel like they should rename advanced EMT to cardiac EMT because of how much of it focuses on the heart and the lungs. This is super valuable. If you can do it and send it in, I'll give you 20 extra credit points.
Hey, Jesse, when you, like, I'm on Navigate now on my iPad, and I've looked at it several times since I downloaded it last class, and I can't find any of this stuff on it. So where exactly are you finding this stuff?
I am going into Navigate now. When you go to your dashboard, you should see a list of chapters. Sorry, I'm cleaning up my mess here while I go. Go to chapter. I just spilled fruit punch all over my laptop. But if you go to chapter 18 and click on it, when you registered with the instructor code, right? You chose instructor
Yes,
load?
and when I go to when I go to dashboard, it comes up my name, and then it says course overview, timeline courses, sort by date, and then it just says And the big blue box under that, essentials for advanced emergency care and transportation.
Yes,
There's
click
more
on that
courses
box.
under that. The view
There's no-
courses.
Yes. Oh, this is gonna taste awful. Click on the view courses, and it should say essentials of emergency care.
Yeah.
And
they're going vertical. It says like chapter 1 EMS systems. They're going, instead of like yours look horizontal, they're all vertical.
Every time I log in, it looks different. Every time I log in, it looks different. So you could see either way, but either way that they line up, just click on the one that says whatever chapter you're looking for. This time, chapter 18. Does anything
extra credit.
go up? You're too far down.
Chapter patient reports. Okay, skills a week.
You too.
Chapter 42.
Yeah, keep scrolling up.
Chapter
They go in order.
41. Oh, how'd I get that far down? Jeez.
You may lose me for a second because I'm changing internets. Okay.
Okay. All right, I got it. Chapter 18, cardiovascular emergencies.
Yes.
All right, so you push that, and then it comes up to learning objectives, audiobook, flashcards, comprehensive slides,
Yes.
focus slides, et cetera, Okay.
Keep scrolling down. And it takes a really long time to load the extras in, so it's going to take me a minute. Because remember, I work 2 full-time jobs, and I'm in school myself full-time. So be patient if not everything shows up right away.
Okay, yeah, I see where you're going now. I just couldn't find it.
Yeah. And you'll also be able, eventually, we're working on integrating everything. You'll be able to see your grades. You'll be able to see your course progress. Once we get FISDAP in there, you'll be able to log straight into FISDAP to schedule your clinicals and document any skills that you perform during Skills Week.
So that paper you said fill out and send in, was that the skill evaluation sheet?
That was one of them. Once you have FISDAP, you may not need that sheet if everybody actually logs the skills they do. However, and I'm going to touch on this for a second while we're still recording, we have a lot of people who are very, very far behind on quizzes and exams. You can't start Skills Week at all until you're completely caught up on those. And I believe, if I remember correctly, that the rules say you can't move on to the next module unless you're caught up, because it's going to get harder and harder to pass the earlier ones to retain that information. But that being said,
that skill evaluation. Sorry.
I'm sorry? Go ahead.
No, I was looking at that skill evaluation sheet. I was trying to find that sheet you were showing a while ago that was below the heart that you should answer and send in, but I don't find it.
Do you see on the screen the building a heart and the human heart lab?
Yes.
Okay, click on those. Actually, click on the human heart lab.
Okay, yeah, I see the picture we started with.
Yeah. So that'll be the lab for that one. Thursday you'll have an EKG lab. Somewhat, it's more tracking your own heart. But you won't have a quiz for Thursday. Or you won't have the same kind of quiz.
Ducky,
Yes, ma'am.
did Robert tell you about me? I was doing the modules in the basic course on Canvas on accident. Did he tell you
Oh,
that?
no, he did not.
Yeah. Okay, well, so module 1 and 2 were complete on mine. They're just on the basic one, and
Okay.
he had told me to start at module 3 on the right one, if that makes sense.
Yes, it does. And I will go in there after we get done and move your grades over so it incorporates them
Okay.
and it shows completed. So, do you guys have any questions? I wanted to touch on I can't go through everything in detail on these PowerPoints. Not to mention, it is incredibly dry stuff, a lot of it. And this is not going to be the first time you get baptized by cardiology. You're going to get it over and over until you feel like the cardiovascular system is the only thing on planet Earth that exists. And then we're going to get into trauma. And then you're going to feel like trauma is the only thing that exists. Be looking at this stuff before you come to class. Read the stuff, get your questions, ask questions. Make jokes. I like jokes. If I can use it at work, even better. I do like torturing my partners. So you're aware the same exact skills that you're going to see during skills week and that you're going to be tested on before you can start your clinicals are right in here. So you already have the answers to the test. Same exact forms we use. Well, we'll use that form too for your test, but National Registries is a little bit different. But you have the answer sheet to everything we can test you on in here. That was my original point. So you ready for your simulation?
Yeah, I don't know what you're
Well,
talking about. Sure.
your tabletop. It's gonna be fun.
Oh,
Contact
yeah.
system. Yeah, and we'll do a kind of fast one tonight because I know both of you are ready to pop out. Oh, it's not as bad as I thought it was. All right, so turning off my screen so you can't see all the handy dandy stuff that I'm about to do to you. All right, so you have a patient calls 911. They are complaining of they're short of breath. Every time they stand up, they feel really dizzy. In fact, they felt like they started to pass out a couple of times over the last few days. That is all that dispatch gives you. And you emergency traffic to the residence for difficulty breathing and weakness. You and your partner, go ahead.
Seems safe.
Yes, your scene is safe. There's a barking dog, but the man standing on the porch is holding it.
All right, PPE on.
Yep.
Okay. I'm going to try to observe the patient, make my initial impressions of the patient. What did it look like?
As you walk up to the patient, you see a female laying in a recliner she's awake and she looks at you, but she just kind of doesn't really talk a lot. She's just kind of saying, I don't feel good. She's pale. What else would you like to know?
Do we go one at a time or?
Shout it out. If you guys get too fast, I'll stop you. But right now, you're slower than a three-legged turtle.
Oh, I thought we were like going one at a time.
Work together.
Oh,
You two are partners. Work together.
oh, I would ask if she has any medication she's taken and if she's had any recent illnesses for sure.
Okay. She tells you, yeah, I take that medicine for my blood pressure. I can't remember what it's called. It's that, it's that Lucina drug. And I take that.
Lisinopril.
Okay, so she's taking lisinopril.
Yep. And I take that medicine for my sugar.
I would check her
That
sugar too.
lipid. Okay, so you want to check her sugar? You get
The glucose.
134. Oh, hey, I also take that medicine that the doctor said it's for my heart, but it makes my lungs feel better.
Okay, probably a diuretic, maybe.
Yeah.
Doesn't know. The doctor just gave it to her for her heart.
All right.
Are we allowed to look on the counter?
Hello?
Huh?
I said, are we allowed to well, I guess she has family there. I meant look at her medicines there or?
They said they don't know where they're at.
Oh, great.
You're in a hoarder.
I'm gonna go ahead and try to get her sitting up a little bit out of the recliner. Go ahead and get her on some oxygen and start getting her towards my stretcher.
Okay.
Whether we carry her or she's able to walk, go ahead and get her where we can start thinking about getting her transported. Ask her what her pain level is, 0 to 10.
Okay. Is there anything else you want to do to this patient before you start moving her around?
Put her on a monitor and see what we got.
Yeah.
Okay.
Vital signs and do you have does that go with you?
If I put her on a cardiac monitor, it's gonna give me her blood pressure. It's gonna give me her pulse rate.
Okay, so that's the numbers you want?
Depends.
I'll give you those numbers.
No, it's gonna give me her pulse rate. It's gonna give me her blood pressure. It's gonna give me her rhythm. Depending on what oxygen I put her on, it's gonna give me her respiration rate.
Okay. That actually comes from your cardiac monitor that the respiratory rate pops up on the monitor.
Correct.
But that's neither here nor there.
That's what I'm asking. Does all of that I'm sorry, I don't know how y'all's stuff is your vital sign machine, does that go with you when you get off? I know I did clinicals, but it was forever ago.
When you go in the house, yeah, you can take the monitor in with you.
Oh, okay.
Especially on chest pain or respiratory patient.
Oh, okay.
Yeah. Quick pause for a side note. Look at the house before you take your equipment into the house. Carry it up on the porch. If you need to, set it down outside. Just quick guide there.
Okay,
you don't
shoot me her vital sign.
Okay, blood pressure is 164 over 102. Heart rate is 63. O2 is going to be 95%, and you told me, or I'm sorry, it's 95% on room air, but you put her on oxygen, and it's come up to 98%. What other numbers would you like? Respiratory rate
we got her blood sugar already.
Yep.
Respiration
is going to be about 14 and very deep. When you listen to her breath sounds, which I'm just going to throw that one in free for you, they sound very wet.
I would ask her if she has any chronic illnesses like congestive heart failure too.
Oh yeah. Well, you know, I told you I have that I take that medicine for my blood pressure. Hold on, something's going on here. We're getting noise. Oh, okay. She says, you know, I told you I take that medicine for my blood pressure, my sugar, and that one for my heart. The doctor says I have that heart failure.
And the edema, pulmonary edema then, because she did say something about it helps her lungs.
Yep, she did. So you're gonna surmise that she has pulmonary edema. The family doesn't really know anything. They came to visit and found her not looking so great.
How old is she
Okay,
again?
so I'm going to.
Her age, she's 72.
Oh, okay.
I'm going to go ahead and ask her if she has taken any aspirin,
No, she
or
didn't take any
if
aspirin.
she's allergic to it. Do you have any allergies to it? Any gastrointestinal bleeding, stomach bleeding?
No.
All right, I'm going to go ahead and give her 4 baby aspirins, have her chew it up.
Okay.
About 3/4 way through chewing her up, I'm going to ask her if she has taken any nitroglycerin.
No, I've not taken any nitroglycerin.
All right. Do you have any prescribed to you?
Yeah, I think there was a bottle there that the doctor gave me. Is that the one that gives
But
me
you
a
haven't
headache?
taken it. Yes, it does give you a headache. That's what I was just fixing to tell you. I'm going to go ahead and give you a spray under your tongue. It's also going to help kind of dissolve that aspirin a little bit. Raise your tongue up, spray under the tongue. It will give you a headache, might make your heart beat a little bit faster.
Okay, but it's gonna make me feel better.
I hope so. We're going to
Okay.
see. I'm going to go ahead after I get that done. Go ahead and get her on. What did my monitor tell me? What's the strip?
You look at the monitor and she is in AFib.
Is her rate
Her,
still 60 some? You said 67, right?
62, I believe. I said.
62.
Yeah, it's still the same rate, but it comes back to the 62, but it bounces. It's, 54, 56, 73. How do you want to confirm that heart rate?
Check her pulse manually.
Okay. Yeah, it feels like it's in the 60s. It feels irregular,
Okay.
but stable.
All right. I'm going to go ahead and get her to the unit.
And
Okay.
give her some blankets.
Okay.
Go ahead and start 2 IVs. Can't see her vein, so we're going to, perfect world, we're going to do 18 gauge. I'm just going to hep lock them or sodium lock them, whatever you want to call them. Because of her possible CHF, I don't necessarily want to give her any fluid, but I'm going to have it there in case we have to have it.
Absolutely. You know, when I got up and walked to the stretcher, I started having a little bit of a hard time breathing again.
I didn't make her walk to the stretcher. I had to stretch her.
When she got up, when she got moved to the stretcher, she started feeling like she couldn't breathe again.
Okay. What's her respiration rate now?
She's breathing a little bit heavy, about 21, 22 times a minute.
Did we do an EKG already? Oh yeah, we said AFib. That's right.
Okay. Since she has possible CHF, I might go ahead and consider putting her on CPAP, see if we can push some of that fluid. Her lungs are wet. We heard those on our auscultation, and she has a diuretic probably. So maybe put her on CPAP, see if they'll push some of that fluid out and help her breathing.
Okay.
And keep her at a 90-degree angle or sitting upright as much as she can.
Okay. She after a few minutes, she says, "Hey, I'm starting to feel like I can breathe better."
All right, keep her on the CPAP and let's roll out to the appropriate cardiac facility.
Okay. The appropriate cardiac facility, and I'm thinking of our area here, is about an hour and 15 minutes away.
Okay, we're going to hold that transport right there and go ahead and see if we can get an ARES back.
ARES back?
Call up Acadia.
I would just call
see if they're
paramedic
out
unit.
there.
Okay. What else are you going to do? Is there anything else you'd like to do?
If we can't get,
Call med control.
say that again.
Okay, what are you gonna, you've called med control, what are you asking med control?
Oh, can you call and ask if there's anything else that, like, okay, so if you're gonna transfer her to another person, is that who you call or no?
No, you'd be calling the physician at the receiving facility typically.
No, I'm saying like, okay, I see. Never
Oh,
mind. I take that back.
You're talking
I
about
rescind that.
Okay.
Yeah.
So not calling med control.
Okay, you could request a paramedic rendezvous with you. I'm not sure a whole lot more they can do. However, it won't hurt if you can get paramedic. I still say we're going to ask for air transport because we have over an hour to the nearest appropriate facility.
Okay. You call dispatch and dispatch says, okay, I'll get back with you. 5 minutes later, they call back. The longest 5 minutes ever. They call back. AirVac says they can't fly tonight. Somebody saw a cloud over Utah.
That is typical. All right, so I'm going to request my ALS unit rendezvous with me, and while I'm waiting on them, she's having issues. I don't think it's safe to pass every other hospital in the countryside to go an hour and a half away. I probably want to get her somewhere where there is an ER and a doctor. Get her stable with her AFib. She may need to be cardioverted.
Okay.
That's my story.
What do you
Oh
think?
yeah, we would put pacing pads on her too, just in case.
Probably not.
No.
I'm just
Okay.
gonna stop that one. Well,
I'm
I'll
just trying to
explain
help.
in a minute. Okay, so you're
Out of scope.
no. You're 15 minutes out from the ER, the local ER, the Band-Aid station.
Okay.
And you've done all your treatments up to this point, and you're gonna call in all the treatments so far that you've told me, and you're gonna call in and give report. Which of you wants to give report?
First
I mean,
off,
I will,
call in
or
report.
she.
I want to reassess her vitals so I can give a current set of vitals before I call in report. It's been more than 5 minutes. It's been 15.
Okay. All right. Your patient's blood pressure is 138 over 94. Heart rate 105. Bouncing.
What's your heart rate?
105. Your respiratory rate has come down a little bit again. It's about 18. Very deep. Crackles. Her O2 is holding at 98. Anything else you'd like to know?
What's her skin color?
She's still pale. She's got a little bit of pallor going on, especially in her legs. Her legs are very, very pallid and very tight. They look about her feet look about double the size of her knees.
That's because she's got CHF and she's fluid overloaded, which I can't do a whole lot for that.
Absolutely. All right.
As they
Any
say,
other vitals?
noted.
Gotcha. All right. So Hannah, you said
We
you want
already
to call
checked
in
her.
report?
Yeah, we already checked her. We already checked her sugar, so that's not all my vitals.
Yeah. If it wasn't normal, I'd say check it again, but since it was, that at least for this patient, once is fine. All right, so you're on the way to the hospital. Actually, you can both take a turn because I'm curious. You've hit the call dispatch button or call the hospital button, and you hear community hospital. What can I do for you?
What are, I guess, are we AAA
You
lifeguard?
can be anybody who you want to be.
Oh, am I going right now?
Yeah, you can go first. Go ahead.
Okay.
And remember, keep it under 20 seconds.
Okay, so we're en route with a 74-year-old female with a history of CHF. She's having her chief complaint is difficulty breathing and general ill feeling. Her heart rate's 105. She was an AFib. Her rate was 50 in the 60s, and it's now 105. And her blood pressure, I don't remember that. Her respirations were, well, she's on CPAP. Okay, I'm sorry. Can we restart mine or something?
Yeah,
I don't
that's
really
fine.
know I don't know what order, like we hear report all the time at the hospital, but now I'm like, I don't really know what all to tell them out of all that stuff we just did.
Yeah, it's very different being on the calling end.
Yeah,
Like, wait until you
now I feel
are
bad.
live. No, don't. We all go through this. Everybody.
What would you leave out? Like
Everything, just about, because they aren't going to listen to about half of it. First General does, but most of them don't. Hey, Miss Donna, you ready to give a report? We'll listen to Miss Donna's and then you can tell me what you think.
yeah, I feel like she's gonna nail it.
Well, she's done it a few times too.
Okay.
You ready?
Make control. This is Donna with Acadian Ambulance 414 Critical Care Unit, bringing to you a 72-year-old female complaining of shortness of breath, chest pain, vital signs, initially 162 over 102, 63, O2 satin at 95, put her on a non-rebreather initially. She went up to 98, her respirations are 14. We have 2 large bore IVs, heparin locked. We have an AFib rhythm on the monitor. We did give her 4 aspirin and 1 nitroglycerin spray, brought down her BP to 138 over 94, heart rate 105, respiration 18, 98% O2. She is a little wet in her lungs, and we know this bilateral pitting edema to her lower extremities. Our arrival time is 7 minutes from your location. Any further actions you'd like us to take?
Dang,
Copy, 7
that was
minutes
perfect.
out. We'll see you when you get here.
All right, thank you, ma'am.
All right. All right, so we're 7 minutes out from the hospital. We've called in report. Anything else we'd like to do?
Continually monitor this patient. We got 7 minutes. I'm going to check her again, probably 5 minutes.
Okay.
Reassess everything I've already done. Ask her, how is your pain level now? It's been, we only gave her 1 spray of nitro. Is her blood pressure, heart rate, everything still doing good? Or is she having increased pain? Because the nitro's only going to last for just a few minutes. I may want to consider giving her some more.
All right. Blood pressure is 159 over 95. Heart rate staying about right at 100.
So her blood pressure is on the rise again.
Yeah, it's gone up a little. She told you she's still a little nervous about the ER because she doesn't know what they're going to do to her when she gets there. Last time it didn't go so well. She didn't like them very much.
They never do.
Yeah.
All
Well, they
right.
have the
What's
things
her
that are
pain
sharp.
level now?
Her pain level, she says, well, about a 5, maybe a 6.
Okay, I think I'm gonna hold off on giving her the nitro. Did we do a 12 lead on her? What does that say?
Nobody ever did a 12 lead. We put her on the monitor. We never did a 12 lead.
So,
All right, so
that,
before I get to the hospital, I'm gonna go ahead and do the 12 lead.
Okay.
Since I got 7 minutes, it'll take me 35 to get it. So let's see what the 12 lead is.
Okay. You do the 12. You place the patient on the 12 lead. You see a fib, some artifact, no other ectopics. Rate appears to be stable.
Okay.
And by the way,
Not much more information I can do with that.
Yeah, not really.
Go ahead. I mean, I can't personally treat AFib, in the unit.
Yeah, I can't either, really.
As a, yeah, so, she, like I say earlier, she may need to get where she can be cardioverted or medicated or what have you for her AFib. I'm just going to go ahead and continue on transport. By now, I'll be there in 3 minutes.
Okay, the patient, you're transporting, you're about 3 minutes out. The patient looks at you and says, am I going to be okay? What's going on? Why don't I feel good? I'm scared. What are you going to say to this patient?
Okay, I'm going to say, Miss Violet, I don't know, let's just call her Violet. I am taking care of you the best of my abilities. We got you pretty well stable. We're going to do everything we can to help you, make you feel better. And we're right here with you all the way there. We're going to take care of you.
Okay. Are they going to be as nice as you are at the ER?
No, they're probably going to be jackasses and scary.
No.
I know I need to add that to her.
Especially considering we have an ER nurse sitting here. No. Critical failure. A good response is, well, I'm going to do my best to see that they are.
my earphone.
Huh.
Sorry, I dropped my earphone.
Oh, you're fine. I'm still laughing over they're going to be jackasses.
Oh, no, I'm actually a tech, and I do most of the EKGs and stuff too. But that's why I was saying earlier, I didn't know y'all could, like, okay, for us, we have to do the EKG to say what the officially, I guess, what rhythm they're in. That's why earlier when we said AFib, that's what I guess I just assumed that we did an EKG. So y'all have a 7 and a 12 lead,
We have a 4
right?
lead and a 12 lead.
Oh,
Yeah, just like you guys have on your monitors that continuously monitor the patient. Yeah.
the 5 lead that we use. Okay.
Yep. Ours are 4, but yes, same thing. So this patient, you've arrived at the ER, you're taking the patient in. The doc's sitting at the desk charting. He looks up at you and says, anything to this? Go.
I'm going to tell him exactly what I told him in the report, that we picked her up in obvious pain, shortness of breath, high fever, fluid, on auscultation. Her blood pressure was elevated, give him a rate and tell him based on her aspirin and nitroglycerin, it did bring her blood pressure, heart rate, blood pressure down, heart rate decreased a little bit, her pain decreased. So yeah, it probably is something to this. You might want to get up and come check her out.
Yeah, that's close to what I want to say, Alette. That is a much better response than one that gets me in trouble of, you make the big money, you come tell me. So, yeah, so 3 words. She appears sick. She appears sick. Keeps you out of trouble, keeps them coming over to check out the patient. Or she seems sick. So anything else you want to say about this particular patient before we start debriefing? I'm not going to make you give the nurse a report yet. Or at all tonight. But anything about this particular patient's condition? Anything that you think you missed or added in and shouldn't, should have and didn't?
I'm sure I missed something because we're just too new to not. So do tell.
Oh, well, I just like to hear y'all's thoughts because I know you think about it while you're talking. I definitely used to. So, big things with this patient, 12 lead at the bedside. She's pulmonary edema. She's going to feel better sitting up. She's laying in a recliner, which tells us that she is a new onset pulmonary CHF patient probably. She hasn't learned all the tricks to keep herself breathing really well. Would you ask if she was taking her medications like the doctor told her to? She would have told you, well, it made me pee a lot, so I quit taking it 3 days ago. I'm really proud of you guys for diverting to the ER when you realized that you could not get the patient to the other hospital in a timely manner. This is not one that we're going to just keep transporting. The CPAP, wonderful. I don't know if you guys have ever noticed, those do have different settings on them for your peak pressure. This normal patients, we start out at 5. CHF patients, a little bit higher, 7 or 10, definitely. Especially if we see all that fluid on them. And you can turn the PEEP up on them. So you start transporting, she still can't breathe. You look at her legs, she's got all that fluid. Turn that PEEP up. You guys did really good about asking about the aspirin. This is not particularly a patient I would want to fly. Even being that far out, I would take her to the closest facility, get a paramedic intercept. They can give her some Lasix or something. And quick reason on that, flights are around $28,000 towards the patient if they don't have the best insurance on earth. She is uncomfortable and she is definitely sick. At this point, she is not in a life-threatening situation. So, and none of this is absolutely right or wrong. You're going to get fired if you do it. Well, some of it is. But choosing how you're going to get the patient to the hospital. If you do what's in the best interest of the patient, nobody's going to say anything to you. Right now, it's about critical thinking. You're going to have these moments. You're going to have to make these decisions. Think ahead about how you want to make those decisions. And that's why I like this. Because there's one of you said you'd take her to the nearest, one of you said you'd fly her. Either answer is correct as long as you get the patient to the hospital. Going back, what if this patient had told you, I don't feel good, but I don't really want to go to the hospital. They got all that COVID stuff going around. How about I just wait a little while and see how I feel in a few hours? What would your response to this patient be?
Then I would have to stress to her the possible repercussions of her waiting. Let her know that we feel that she is sick and probably does need to be seen by the physician, by the ER. And if she adamantly refuses, after you've told me she stopped taking her medicine, that she should probably go ahead and take her medicine. And if she just insists she's not going, in my mind, I'm not going to say that's when I'll be back later to do full-blown cardiac arrest on you. But, if you're not going to go, then I suggest you get in contact with your family physician and make sure she signs the AMA.
Yeah, absolutely. And another resource you have, call your medical direct or your med control. Be like, hey, this patient's sick. They need to go to the hospital. They're refusing. Can you talk to them? Give them the lowdown. Put that on them. And a lot of times when the doctor gets on the phone with the patient and says, yeah, you need to go to the hospital, they're going to go to the hospital. Especially these sweet, never offend anybody little old ladies. Know your audience. And I know you said you'd be kind about how you said it to her. A patient this sick is not somebody that you're going to sugarcoat things to. The first time I RSI'd a patient, she actually tried to refuse going to the hospital initially. And I looked at her, and I looked at the ambulance, and I looked back at her, and I said, well, you might want to get in touch with the funeral home and pick you out a casket, because by the time I can get back out here, when you call, as soon as I leave, you're going to be dead. She was in pulmonary fluid overload. Every time she coughed, fluid was coming out of her mouth and nose. She was sick. On the average everyday patient, watch what you say. If you have a patient that you truly feel is going to die, give them the bacon version. Make it as clear as you can that they are not doing well and they need to go to the hospital. Get the medical director on the phone, have your partner talk to them. It's situation dependent. Going back to treatment for this patient, this is not an aspirin patient. If aspirin we give for chest pain when we can't find or when we know it's cardiac, STEMI type of cardiac, or if we can't find the cause, nothing showing up on the EKG, and they're complaining of chest pain symptoms that match a cardiac underlier, a STEMI type underlier. This patient, we know it's an edema issue. Aspirin's not going to do anything for this patient, and because she's already has AFib, she's likely on another blood thinner. She just doesn't remember it. So,
Gotcha.
pulmonary edema, oxygen, nitrogen, morphine if you're a paramedic and they seem like they're in excruciating pain. This is not an aspirin patient. I'm really, really proud of the fact that you guys did not try to give albuterol. That would have been a me losing my mind moment. Because if you give albuterol and open up this patient's lungs, what's going to happen?
They're gonna drown.
Yep. The fluid is flowing into them from the bottom and flowing up, building up. So when you open up the lungs, you're just making more area for that fluid to come into. Those are the big ones. You guys did really good. Hannah, try to practice calling reports. Listen to the ones at the ER. Keep it under 20 seconds. You want to give what's wrong with the patient, how old they are they stable or unstable? And
Vital signs and heart rhythm, right?
Yep, heart rhythm's one of your vital signs now. And
okay.
if there is something extra, if this patient was, and it's situation dependent, what you tell the ER. This patient is currently stable. She's alert and oriented. Her blood pressure, heart rate, respiratory rate, crackles on inspiration and expiration. We'll be with you in about, they'll ask for a GCS sometimes. So try to get in the habit of giving that. I don't a lot. And half the time they ask, half the time they don't. For a medical patient. keep it short and simple because they have 15 other ambulances trying to call in. They just need to know if they need to get you a bed first or not. Oh.
Yeah.
My headphones went out. Okay, I swapped you over to my computer because my headphones just died.
Oh wow.
Yeah. But I've been using them all day while I've been driving and not charging them. So, again, really good call-in report, Donna. Hannah, I'm glad that you tried and you did good. Keep working on it, okay?
Okay.
What else? What else? Yeah, get in the habit because you're going to be the primary one with the patient. You're not just treating them medically anymore. You're not just, leaving the patient in the hands of somebody else. Get in the habit of being their source of comfort, especially patients with true medical events that are scared, that may have had bad interactions previously at these hospitals. You're learning a lot more stuff to treat the patient medically, but that means they're your responsibility, your child now. That you're the one that's going to have to advocate for them. Or to them. Sometimes their biggest issue is their own brain. You guys have any questions? Because I feel like I've hit that horse on the head enough times. But these scenarios are going to get more and more involved, especially the affect portion. You guys know the basic stuff. You're here to learn certain skills, and learn how to be in charge of that ambulance. Which, Miss Donna, you're a paramedic already, if I remember correctly, right?
Yes, I was.
Oh, you missed the dark side.
Yep.
Yeah.
All right. All right. Well, does anybody have any questions?
No.
There's a lot to think about, and we're gonna go a little more in depth Thursday because that is just no PowerPoint, no trying to read those slides for this stuff. Just a in-depth look on how these disease processes affect the heart and how it functions. I'm going to stop the recording now because that's all the useful information for that. And I will talk to you guys on Thursday. Those of you still in the course live, stay with me for a minute.